So thank you very much for that introduction. International. I know what they'd be saying in Highlands now. They do this wonderful thing where they say, don't get above yourself, and they sort of do this. So I'm just grounding myself here today, and it feels like I'm with friends. So I hope we can have an enjoyable day, make it as interactive as we can. I've got a couple of things to do if you look like you're getting a bit bored. So I've got lots to talk about, lots I could spend all day, but I promise not to, and we will keep to time, so we will finish at 1 o'clock. But if there are things that I'm saying that you want to ask me about, do feel comfortable enough to just interrupt, and we'll answer things as we go along. So I'm Elaine, I'm from NHS Highland, I'm Chief Exec up there, and it's a real privilege to be able to have that role. It's important for us as leaders then to think about what our role is, and I was interested to hear Michael West in his, I think it was at your last Masterclass that you were all together, talking about the leadership shaping actually the culture of the organisation. And I want to focus on that quite a lot today in our description of what we've done in NHS Highland. I do want to say, though, that we're on a journey in NHS Highland, so I wouldn't want any of you to think we're coming here to tell you how to do it. All we're coming to tell you is what we've done and explain to you some of the interesting things and some of the difficulties that we've had on that journey. So I hope it will be interesting. You've all chosen to spend the time here today, so do spend that time in the moment and get as much out of it as you possibly can. So, this makes me feel like I'm at home, and there are two parts to the story that I'm going to tell you. You can tell from my accent, and I'm sorry you'll be disappointed I haven't got a beautiful Scottish accent, because I'm obviously not from the Highlands, but actually my family live in the northwest. But I was born here in Ely, and I'm planning to go and have a look at it, because I've never seen it in the daylight ever, so I think I need to go and have a look at Ely sometime before I go back to the Highlands. So let me tell you how the plan of the day is. We're going to work till 1 o'clock, but we have got a break in the middle. I noticed the improvement. People couldn't keep their hands off the Tunnocks tea cakes that I've carried all the way from the Highlands for you. And I'm going to, as I say, try and put this in some context for you. Again, Michael West was talking about context being really, really important. So let's start there. I'm just going to take you, if I may, to Scotland with me. So it's a small country. Just over 5 million people there, and you can see the lovely tartan picture there with the health boards described there as 14 health boards. And we are quite different. One of the reasons I actually went to Scotland was because the English system, I moved to Highland from the south coast, I was actually in Dorset. The English system was moving almost in a diametrically opposite way and almost experimentally from where England and somewhat Wales were going. And I was very interested in integrating services. So in Scotland, the services not only were moving towards integration, but now, and I'll describe to you, that there is legislation to push that further forwards. The legislation is under the Scotland Act, and of course Scotland, as you'll know, will be has been devolved, and health and social care is a devolved matter that the Scottish Parliament can actually pass laws, and they have gone on to do that. So this is Holyrood, beautiful building. Lots of people argue about the amount of money that was spent on it, but it's a beautiful building and feels actually very European in its style when you're in there. So if you're ever in Edinburgh, do have a look at that. The Scotland Act then meant that Scotland is a devolved government, so they do make laws on a whole number of things. And the most recent one of relevance to the conversation we're going to have today is the Joint Working Scotland Act, which actually only received royal assent last year, and it has now meant that all health boards and local authorities will actually integrate health and social care. So it's no longer you would, if you'd like to, this is now law, and you will do that from the 1st of April. So that has caused all sorts of chaos, as you can imagine, as we all scurry to take one of these models. And in fact, the models, I'm afraid in Highland, we've gone and confused people because we've chosen a model of partnership and integration, which no other board in Scotland has chosen. So most boards in Scotland you'll hear describing a corporate body model where they're two options where the two organisations come together with an integrated joint board, which is option 1 here. And they had to put in option 2 because in Highland we'd already done this. So this is a lead agency model, which I'm going to talk to you a little bit about today. So I wanted to give you a sense of the scale and the size. So although NHS Highland is geographically the largest health board in Scotland, actually it only serves a small population of 320,000 people, but the distances are significant. We also provide services to 26 inhabited islands, lots of single track roads, some of the most remote and rural parts of the UK. So that's to just give you a sense of where we are. Budget 750 million, and of course that's now including integrated health and social care. This is the sort of road, I don't think you really drove down today, but this is our A9, and actually it was as bad as that yesterday, if not worse. And there are three areas I would say that are interesting about Highland that I'd like to share with you. And I think they're interesting, you might not, but we'll talk about them anyway. And that's our remoteness and rurality, that I won't labour too much, the model of integration and what we've done around integration, and our focus on quality improvement. So in the next couple of hours, I'm going to try and bring those together and take you through the journey that we've been on. So it is beautiful. It is a beautiful part of the world. It has its challenges, as you do in some parts of your area, in delivering consistent, high quality care. And that's really very important for us. If you have a look at this picture, and I wanted to just touch on the remoteness quickly, you'll see that most of the services, the red little pins are the GP practices, and there are a couple of hospitals. We've got 4 hospitals in Highland. They're around the edges of the geography. And any of you that have been to Scotland or have spent any time or know Scotland will know that some of that is to do with the Highland clearances. So that was a real major issue for the Highlands, where actually the landlords remove people from the localities and they replace those with sheep farming. So you can see most of the services around the edge, and in fact the straths in Highland haven't really been repopulated particularly. So there are small populations of urban, by our scale urban, not hugely urban, but Inverness would be a city that's actually one of the fastest growing cities in Europe at the moment. But I put this up just to tell you that actually a very wise GP told me this my very first week. I was worrying about the geography. How did you get around? What did you do? How did you provide services? And he quite rightly said to me that in Highland, history is for them more important than the geography. And that's actually been a very wise lesson, because people then are very, very concerned about letting go of things because they've had it like this for a long time. So that makes any of the change you're doing that little bit more complex to deliver. Integration, I'm going to major on this today, the lead agency model, so I'll describe that for you in more detail. And the Highland quality approach is what we're talking about better health, better care and better value. So you'll see me put up this triangle, it's branded. Those of you that have been working in quality improvement might recognise this as being very similar to Virginia Mason in Seattle, and I'll come back and talk about that as well. So let's just start in Highland then. So what is really different about the health board in Highland is that we, under one health board, one governing board, although we have operational divisions, provide all of the services. So all of the acute services, pharmacy, podiatry, we've got community nurses, we have contracts with, we have salaried GPs, but we have contracts, of course, with independent practitioners. So it is a wholly encompassing health system, which does make sometimes things easier to do than often having the fragmentation, which sometimes is difficult. But for me, it's not actually about the structure, although we have had to make some structural changes, and I'll describe those. Put these up mainly for reference. Population will be the same as yours. We're having difficulties with an increasingly ageing population. Highland's no different. We'll be expecting to see a significant increase by 2031. And we need to be planning now, and in fact we've been planning for the last 10 years for this increasing population, because you can't turn things on quickly and turn them off. So we need to make sure that we've got our services there and in place. And again, in Scotland, this is what we lovingly call the triangle of financial doom. I don't know, do you have one of those south of the border or not? No? Yeah. Okay, you have one, that's fine. So we're right in the middle here now, 2015-16. This is the deficit, this is the gap that we're going to have to fill. People often show this, heads in their hands, isn't it awful, how are we going to do it? I feel a little bit different about this. I think that this is the opportunity for us now to take waste out of the system, to absolutely reconfigure services. We had a huge, and still have a huge amount of waste in our systems, that if we went back in 2025 to 26, do you know what? We'd just carry on doing the same old things we've always done. And in fact, we need to, as leaders in the organisations, take this opportunity to say, this says we can't carry on doing the same thing. So now, and you'll feel that burden of responsibility as I do, how do we genuinely reconfigure? It's both a privilege to be a part of that, but this is something that miss this opportunity at our peril. So elderly population, financial constraints, we have to change. Multimorbidity, again, common in Scotland, in some areas of high deprivation in Scotland, and you will have heard of the sick man of Scotland. Lots of older people now, we're not any longer looking at people just with one illness in old age. We're actually looking at people having 3 or more conditions, and even now seeing young people with comorbidity. So the whole dynamic of healthcare is changing. And obviously the multimorbidity after 10 years in the most deprived areas of Scotland, you'll have similar sorts of data here. So it's not different, it's really what I'm trying to say. And when we look across the UK and wider, we see these are similar trends in other countries. I put this up as a consultant, Jerry Trisham, gave me this slide, and he likes to describe comorbidity as buckaroo. And that comorbidity buckaroo is, I think, helpful for us to recognise that older people have lots of things wrong with them, and tiny things that we keep adding to, and things that we try and do for people. And then you put the last problem on the top. And it might be a tiny thing, but the buckaroo says that's it, whole thing breaks down. So having a focus on actually the individual and what they need for the future to keep them well, I have that comorbidity buckaroo picture in my head, and I apologise because you'll have it in your heads now forever, and I'm sorry for that, but it was Martin's fault. So again, just to give you some context, the triple aim, IHI, our triple aim, we were inspired by this a number of years ago. So bringing together then better care for individuals, better health care for populations, and lower costs seem now to resonate more than ever. And of course, we're now moving away from being a service that makes sick people better to actually, obviously, a service that keeps people well as long as they possibly can be. So we have interpreted the triple aim in our Highland quality approach, and our interpretation is this: putting quality first always to deliver better health, better care, and better value. And that putting quality first, I'll keep coming back to, because it's really important that you live by this. That it's not just something that looks shiny on the board papers, it's actually something that you genuinely believe and you genuinely will do. And sometimes that's very challenging, but we found if you do focus on quality, your clinical community will come with you and will stand by you through thick and thin. So we have integrated, and I wanted to just give you a bit of a scale of that, because a lot of focus will be around health and social care integration. I think all of you in the room would agree with me that actually health on health integration is probably one of the most difficult things to do. So continually we're trying to integrate, although I will describe the structural change we made back in 2011, and we've made another change that I'll describe in 2016, and that will happen, as I said already, due to legislation from Scottish Government. It's all about redesign. It's not just about structural change. You can do this without any structural change. A lot of it then is about how do you engage people? How do you get people to put others at the centre of everything that we do? So I'm going to make you do something now, because in any of our board meetings or anything that we do, we like to ground people by saying, what's the most important thing? And this is Dennis, and I wanted just to describe Dennis to you before we went any further, and then I'm going to ask you to do a tiny bit of work. So Dennis is a man who really exists. He lives alone in the community. He's a father, but his children live far away, and he's a widow. Dennis had a brain tumour a few years back and it was treated, but his post-operative recovery was complicated and it took quite a big effort, lasting more than 12 months actually, in 3 hospitals to actually get Dennis back to where he came from. We're now 18 months later from that and Dennis's tumour is back and he can't speak. He's on medication to prevent his seizures and he does get slightly mixed up. So he turns up to places sometimes with out-of-date appointment cards, for example. So he seems unreliable to people in his use of the drug dossett pack because he's muddling things up. But he does live independently and he lives independently with some help from friends and neighbours. He's up, dressed, out of the house at 9 o'clock. He's in bed at 9, but he locked himself in, so you couldn't get into the house without breaking in. And his daughter, worried living away, actually hired a carer who calls in daily to check on him and supervise his medication and self-care and his nutrition. So everybody agrees in the whole team that Dennis is, of course, going to die at some point, probably because of his brain tumour, not necessarily, but probably because of his brain tumour. But everybody can see that Dennis is happiest in his home. And that's his familiar surroundings. So all of us would like to keep Dennis at home as long as we possibly can. But in all honesty, it's only a matter of time before something tips the balance and Dennis's independence comes to an end. So you'll all know Dennis is. What I'd like you to do on the tables in the big brown envelope that you've got here is the story I've just described to you. And there are some scenarios. There are, I think, 4 different scenarios on different tables. You've only got 1 for each table. And out of those 4 scenarios, they just describe something that's happened to Dennis. And I'd like you just to spend 10 minutes, if you would, on your table, just talking about what would be the impact. There are some questions at the bottom of the coloured sheets. Just have a conversation for about 10 minutes about what would happen to Dennis in your area, in your partnership, and what would that mean for Dennis? So I'll let you just orientate yourself. We'll only take a few minutes on this, so just have a quick chat about it. Okay, so let's have just a tiny bit of feedback. If I can just bring you back together again then for a second. So, not going to go through a huge amount of detail, but wondered whether it might just be helpful because you had 4 different scenarios, and I wondered whether we could maybe pick up on one of the pink tables first of all, just to give us a sense of what was happening to Dennis and some of the issues. So, I've got 1 pink table here. Would you like to give us a bit of feedback here?
So, would you like me to run through the scenario?
Just the headlines of it, please. Just the headlines, so you can hear what happened to Dennis.
Okay, so Dennis was admitted to hospital, acute hospital, following a fall. He was discharged home on day 3, and there was a significant debate within the MDT team as some staff wanted him to have a couple of weeks rehab, i.e. physio and OT, and a home visit to assess his care needs. Other team members wanted speech and language input and a psychiatric opinion to determine the mental capacity to make decisions. While he was in hospital, he was noticed to have blood sugars running high between 10 and 12, and he was on steroids to reduce the swelling around his tumour. The nub of the issue, I think, was there was a disagreement on discharge home between the GP and the senior doctor as to whether he needed to be placed on the diabetic register. The GP had already made a decision to avoid lowering Dennis's blood sugars due to the long duration of treatment needs. And he felt he wanted to have a look at the effect and the increased risk of problems with more medications. So within our team there was some discussion about how those tensions between perhaps the acute and the community would be resolved, and certainly within our situations the expectation would be the GP would probably have that conversation with the doctor in the acute setting. We've also got the options of community hospitals where we are in Norfolk. Mm-hmm. So quite probably Dennis would have been stepped down into a community hospital bed before being discharged directly home. And the other option we've got within our setting is that we have, as of next week, a community assessment unit within North Norfolk. So potentially, rather than going straight into an acute setting, mm-hmm. Dennis may be assessed for a sort of period at a local hospital and a determination made whether he could be supported at home or whether actually an acute admission was warranted.
Excellent. Okay, thank you. So that's really helpful. Are there any other things to add from the pink table here? Thanks, Tracy.
Hi. In the multidisciplinary team, I think they've raised quite a few issues. Mm-hmm. There has been a conflict between various members of the team.
I expect that never happens here, does it?
It does happen, but the patient was then decided to be discharged home, where some members of the team say that he needs assessment. Somebody saying he needs a SALT assessment. So there has to be some kind of coherence or cohesiveness before the patient was decided to send home, and then he should have been handed over to the community team or the GP. GP is probably not a specialist in diabetes, but he is a specialist in his patient, so he knows how this gentleman, or how Dennis is in the community, what he likes to do, what he wants to do. And I think Dennis is, I'm sorry, I'm saying patient. Dennis is now in that realm where he can be called palliative. Mm-hmm. So where on the spectrum of palliation is Dennis? Is he just a palliative care patient, or is he at the end of life?
Fascinating question, and we'll come back to that, I think.
And we have to decide how bad is the risk of Dennis dying in the next 3 months. So maintaining his diabetes is important, or to keep him comfortable is important. Sure. And that communication with the next of kin is vital. Okay,
great points, and those are exactly the things that we want to pick up on. So thank you very much. Let's just move to the yellow table here, Tracy, if that's okay. So you had a different scenario. So can somebody just give me a 2-minute heads up? Who's going to grab that microphone? Thank you. So could you just tell us what the scenario was?
The scenario was Friday evening, and Dennis rings his alert buzzer. Ambulance attends. He's found to have a worsening of his previously mild face, arm and leg weakness, still mobile and eating and drinking with assistance. The ambulance calls for the GP to attend. The GP attends and agrees the weakness probably worse than baseline but not severe. Notes history of a brain tumour. The GP has the following options. Follow the FAST protocol and immediate transfer to Regmore for CT and consideration for lysis. Number 2, try and manage at home on the basis that he has a known brain tumour and unlikely to be for lysis. Would seem to need some more assistance than normal. And the FAST protocol is a system by which all suspected strokes are fast-tracked directly to A&E, bypassing the GP to facilitate rapid CT and consideration of thrombolysis. And so we were looking at, I think it might be useful to kind of have some intervention here from my colleagues in terms of the current system as to what would happen to Dennis within Luton. So if you it'd be helpful for you to handle that.
Okay. Can't quite hear. Okay, just lift it up. That's
fine. I mean, one of the first things we looked at was really, because it's a Friday evening, our local services it would be outsourced to so it wouldn't be a GP necessarily that knows him. So the first thing we thought about was the risk, really, whether that GP would take that risk to consider option 2 and keep Dennis at home, and would he have enough information to be able to make that decision. So a lot would be around what had put in place previously for Dennis around the knowledge that's there about his advanced care planning, whether he's known to our local My Care coordination team, and again, picking up on your point about the palliative, whether, how long is he in his palliative trajectory. So there was a lot of what-ifs really in that scenario, but we did come down to the risk really that the GP would need to take about where's the safest place, thinking about any potential consequences about making that right decision at that time.
Absolutely.
We have, potentially, if we had that care planning in place, we've got some resources where we could look at how we could support him at home. We haven't got community beds, but certainly we could have access to rapid social care support. So a lot of it is about that pre-planning, I think, for Dennis.
Sure. And wrapping round Dennis.
And what he wants and what's
exactly
he's planned, really.
Excellent, thank you. So I think, is that yellow table behind you there? So were there anything you wanted to add there from that same scenario? We covered those.
Hi, sorry, we're GPs on our table.
Oh, so you would have been, I knew you'd all be going for that technical.
We've got some practical experience
Indeed.
with this. I think the main issue that we came across was, what does a patient want? Where's the discussion with the family?
Sure.
is this patient truly palliative? Does he have, what's the prognosis for this patient? Is this someone who needs to go in immediately if his weakness is a lot worse? He's not managing already. Does he need somewhere that can actually support him? And I think one has to be realistic. Can he manage at home despite his wishes? If you can, then you try your best to do that.
Sure.
But does he need a short period where he has everything done for him, so everything is in place so he can go home and be comfortable? The worry is, does he understand the risks involved? He might deteriorate, he may not be able to feed himself, or his once-a-day carer can't feed him or do his medications for him. He might decline further. The GP is not going to be there at the weekend. Does he understand that? And I think you have to really go through all of those risks with him. The other aspect is, does he have capacity? Does he understand? Is he able to understand, especially with this worsening in function? Is it a brain tumor, or is it a stroke that he's having? Is this a thromboembolic event? Something else is going on that's making him much worse? And has the palliative care team been involved? So if the GP is very good and they're able to say, okay, you don't want to go into hospital, what can we do for you at home? You might get the rapid assessment team to assess him. It may be the social care, maybe carers that he needs rather than any medication. It may be physiotherapy that he needs. It may be something else. So that's one aspect. But really the Macmillan nurses would be very useful because they can come in and offer evening care or overnight care. And maybe that's what he needs in this instance.
And I think as a GP, what you're describing then is it's not just the GP that's going to sort out Dennis, it's a whole team of people, and picking from those teams and trying to coordinate that care for Dennis is going to be crucial. Yeah.
If he's unwell, I know there's mention about cost in this scenario. People always say that hospital is very expensive and the care may be a few £100s a night. But if you're trying to get a service, if the service is already there and you've got out-of-hours social workers, out-of-hours physiotherapists, out-of-hours occupational therapists, out-of-hours GPs, one also has to think about the cost of that for one patient.
Of course.
Whereas do you do a quick assessment, and do they need to be in a community hospital for a day or two? Do they need to be in A&E for a day or two in an acute hospital, or do you just keep him inside the house? So you have to really think about costs as well.
We do.
Overall.
Okay, so I'm going to stop you there because Dennis is so real for you GPs now, isn't he? I can tell that you've already worked out what you're going to do with him, so thank you for that. I'm just going to take the family scenario, the press scenarios. I think that's on green paper, is it? Yeah, so can I just hear from, if you take just to the back first, Tracy. So I won't do the fourth one, but can we just have somebody just give us a summary of that one, because this involved the family.
Yeah, this one's all about the family, really, we think. So briefly, he is admitted into hospital because he's had a fall and he's unsteady on his legs. There's an assessment which suggests there's nothing new and the risk is pretty steady. There's a conversation with him. He's discharged home that night at 2 in the morning. He has a fall again, and he's fractured his hip. Has a long and difficult stay in hospital while that's sorted out, and the family complain. There are unpleasant press headlines and so on about terminally ill men being thrown out of hospital.
Okay. Familiar scenario ever? Ever heard that sort of thing? Yeah. Okay.
So, the core issue, and there are lots of things in this, but the core thing for us is about whether the conversation happened with him and with the family about the degree of risk that people were able to accept if he were to be discharged home, whether the family were truly on board around that.
Okay, and thank you, because I think we hadn't touched on the risk element and the family's involvement in that. So just let me say, was there anything else you wanted to add to that from the green table here? Came to the same conclusions, did you? Yeah? Okay, thank you. So I haven't got time just to go through the last scenario, but I hope those are helpful just to, again, bring Dennis into the room for you to think about sometimes disjointed services and how we have to wrap around what the individual needs, what the families want for Dennis may be realistic, may not always be realistic, what the costs are associated with that, but most important, what does Dennis really want? So I hope that was helpful for you. You're welcome to use this, these sorts of scenarios, and we sometimes find it's helpful to working with something that people can engage with because it's actually tangible. These are real things that have happened to people, and they have to put aside their views and have a conversation about the rest of the team. So thank you for participating in that. We'll just work through to coffee then, just with some more slides, if that's okay. So let me take you then to the ambition of NHS Scotland. So NHS Scotland has a 2020 vision. I think that's coming up on us very quickly, so it might be moved to a 2025 vision or even further. But again, that's safe, effective and person-centred care to keep people at home, if that is what they wish to have for as long as possible, in a home or a homely setting. So I think you'd agree that's what we would want, and certainly that's what Dennis wanted, and that's what our ambition is in Scotland to try and do. So I want to, before the break then, just describe to you what the lead agency model is. And as I say, it's on a journey. We're not describing this as the panacea, but we're just trying to show how we went through a process to make differences to how our care was integrated in Highland. And there was a really important set of reasons that we wanted to integrate. Lots of the things we've touched on in the conversation there. Finding that patients were left in hospital because there were no alternatives to care. So being called delayed discharges and bed blockers and all of those other things that feel so uncomfortable when it's a real human being behind it. And knowing that even in hospital, it's fine if they're getting care because they need to actually have some health need met. But in fact, if they're just delayed, becoming debilitated more and more day after day, which absolutely we need to be focused on. In Highland, we had limited care at home services. They weren't really joined up. We were blaming each other, and I'll describe a little bit more of that. But we had done a huge amount in the community. So we had some of the options that you were describing across this area. So we'd already got anticipatory care plans for all of our older people in care homes and, sorry, not in care homes then, it was all of the older people on identified from a risk of readmission to hospital scale. So those people had got anticipatory care plans, and those plans were not just for their care, but what happened if their care broke down. So it was if their carer became unwell, for example. We were using hospital at home, virtual wards, those sorts of things. So again, this is nothing new. It's about how do you coordinate all of that effort. And one of the most important things that we did was actually look at polypharmacy. We found that huge numbers of drugs that people had put these individuals on over a period of time, and we had a massive impact by going through and actually with my comorbid geriatrician actually going through and spending more time taking people off drugs than putting people onto drugs. So in our hospitals as well, we put in front door work to try and stop people coming in. So if we could possibly prevent unnecessary admissions. And of course, for a GP at 4 o'clock on a Friday night, if there's no alternative, it is a necessary admission. So this is an admission where actually we could have an alternative. So acute physicians, we started talking to people about assessments, not admission, to lower people's expectations. Lots of the things we did, again, on hospitals, in the acute hospitals that you will have already done and I'm sure would be very familiar to you. But I describe that because although this is only data up to 2013, you can see on that top graph there the trajectory with the Highland residents for emergency admissions to be expected. That dotted line was going up significantly. So all of those other things that we've described on those first two slides there actually managed to start to plateau that out, even against an ageing population. So we would know that we would have less bed days used in elective care with the new technologies, anaesthetics, etc., but the emergencies were where we were trying to have the biggest impact, and this was actually part of the integration and pre-integration work that we did. So with our partners, the Highland Council, I would say I spent far too many hours sitting in rooms with the top people in the council arguing about whose fault it was, because it's always somebody else's fault. So actually that frustration of we were doing quite well, so it wasn't broken, but actually we could see this huge number of older people coming towards us and it just wasn't going to work. So a lot of it was because people were absolutely siloed in their responsibilities and their budgetary responsibility particularly. So if I was a social worker, actually it was quite convenient for that patient to be safe in hospital because it doesn't come out of my budget for the minute. Now I might not be saying that out loud, but I sure as hell was thinking that, and another few days of actually not assessing that patient was a few days off my budget. I would equally say, if I was a hospital manager, I would say, let's get these people out as fast as we can. Let's not have them in here at all, because actually I don't want them in my beds because that's my budget. And people were really struggling because their focus was on what they had responsibility and control for. So that's silo thinking. And these were people that had been working together for years. So they knew how to do it and they knew what the difficulties were. So we needed to look for some alternatives, and this was the real focus we wanted to have. Focus on the dentist, focus on the individual. For the health and social care pound to lose its identity. And that's a really critical thing for us. What we actually wanted to have was a single budget, single management, single governance, so that you could actually move from one thing to another. And I ultimately was still responsible, but the team felt responsibility for everything that was happening across the whole sector, rather than that's a social care problem, that's a health problem. So we wanted to break down the silos, and the lead agency model for us gave us an opportunity to do that. And we first were talking with the Highland Council about potential for discussing older adults particularly. That's where our biggest problem was. But we started talking about, well, okay, if this model works for older adults, then what about people with learning disabilities? What about people with mental health issues? Why couldn't we think about everybody, that actually we could work in a whole system? And we even then went on to say, okay, well, if we've got that logic nailed, what about children? Why would it be different for children? Why shouldn't that all be integrated in one organisation as well? And once we had that breakthrough, once we started thinking like that, we started having a very different discussion with our local authority, because it became apparent to us quite quickly that actually the health board was not the best place to actually manage children's community services. We were very good at doing it, but the real prize was going to be integrated with children's community social work, but also education, and we were never going to take responsibility for that. So we started having quite a different discussion then with the council. The conversation was around this: who would be the agency that would be best placed to deliver these sorts of services now, and who would lead on those? So we had a structure like this, and what we ended up saying is, how could NHS Highland and the local authority, the Highland Council, work out what would be better? And we moved in the end in our discussions to this model, where we suggested that the adult services, all of adult care, would be delivered by NHS Highland, and we would be commissioned to deliver that through the Highland Council, but the responsibility, and that then was for adult social care, remained with the council. The accountability then came across to me. With children's services, again, we decided that we would then transfer our community, not our acute, but our community children's services to the Highland Council through a commissioned arrangement with them. But the responsibility for them still remains with me as the Chief Executive of NHS Highland, and I'm held accountable in public for any health services. But they were delivering it day to day. So this was quite radical thinking at the time. And in fact, we had the First Minister up who she was the Cabinet Secretary at the time, Nicola Sturgeon, and we sat in the headquarters in the Highland Council and said to Nicola, okay, we're thinking of doing this, what do you think, happy with this? And she said, I'm absolutely supportive of this, providing it works. Okay. That's the sort of cover you like from your politicians, and fair enough, she wasn't stopping us, but we needed to make that work. So This is where then, I've already put and described this for you, but you can see that option 2 is what we were talking about. And that now, because Highland had moved to this model before the legislation, that now is enshrined in the legislation in Scotland, because our lead agency model was different. And it required us to give up power, which is a really interesting thing for us maybe to touch on a little bit more as we go through today. So, this is what we transferred. We transferred then 1,400 adult care staff. So those were care staff in the community, social workers, care at home workers, care workers that were in care homes, were transferred from the Highland Council, about 90 million, over to NHS Highland. That's what happened. Chupied over. Still maintained their council terms and conditions, but chupied over, so they're now NHS Highland employees. And the quid pro quo was actually very much smaller, but 200 staff from NHS Highland were transferred over to the Highland Council. These were children's community staff, AHPs particularly, family health nurses, transferred over. About 8 million in that budget. And the biggest noise, can you guess where from? Any ideas? Royal College of Nursing. Because of some of these 200 staff were nurses. And there was a genuine grieving for the NHS brand for some of these staff who've been trained in the NHS and suddenly felt going to the council would be disastrous, would have all sorts of connotations, would be really difficult. People, they were telling me, would say, if I work for the council, they'll say, somebody's trying to take your children away from me. I look to my children's colleagues on the table over there. I'm sure those will be issues that your own teams would be familiar with. But we had to hold our nerve on it, because we had to say what was going to be the most important thing for the people of the Highlands. And that was what we wanted to do. We had a clear statement. And it was quite interesting in the council chamber, that date in December 2010, where we had complete consensus across all parties, across all board members, to actually take the steps to move towards integration. And that meant that there was something very right about what we were trying to do. How we were going to do it at that point, we hadn't got the faintest idea, but the idea was good. But to get that sort of backing for everybody to accept there was something more important than what just their little bit did was probably the brave step, I would say, that the council and the health board took at that time. So this is now what we would see. We would actually have, as NHS Highland, we are now responsible for delivery of care in care homes, care at home, social workers work for us. And it's not about a takeover, and it never was anything to do with that. So the reality was that we moved across from having two separate organisations into one, and we wanted to go live very quickly by April 2012. We knew it would require transfer, and the most important thing is probably on the very bottom of this slide that you might not be able to see from the back, but it says that both myself and Alistair, who's the chief exec in the council, agreed that if there was any detriment in that period of time while we were working this up to children or adults as a result of the work that we were doing to integrate, we would stop the line. We would actually stop, go back to the board, go back to the council and say, actually, can't do it. And we painfully worked through a process of understanding every single thing that we possibly could. And we had a log issue as long as your arm that anybody could add to, but we worked our way through it. Plenty of things that they tried to stop this happening from. So this was the transition board, jointly chaired by Alistair and I. We had to be strong, we had to be visible, we had to have a team that were working on some of these log issues to understand what was going on. And we had to work with staff representatives. So we call that in Scotland partnership. We have staff partnerships, trade unions sit around the table with us, because there were lots of really tricky issues that we needed to sort out about this transfer. And as I've said already, there was a very quiet watching brief from the Scottish Government because they wanted this sort of thing to happen but couldn't see how they could make it actually happen. So we spent quite a bit of time trying to bust myths for people. One of the stop the lines for us was actually some paediatricians raising that there would be significant child protection issues if we did this. Now, you can imagine I'm jumping in the car, driving to the paediatric team and saying, okay, tell us about that, because that's obviously really important. But I went with my colleague from the council. The paediatricians gave us a long then story about how awful it was that if we had this change, then the real problem was that there was a threshold for intervention that was different between health staff and actually social care staff. And that would compromise child protection. And I'm saying, okay, that is an issue. Tell me why integration is causing that problem then exactly. Yeah, nothing to do with integration. We just thought we'd tell you that that was a problem for us. Okay, so I described that to you because actually that was a problem we needed to resolve, but it was nothing to do with integration. But people were throwing things in all the time to say, you can't do this. People will die. And that was not the case, and certainly today isn't the case. So the open log issue, where everybody could log whatever they wanted, was an important thing for us, and we took everybody's concerns seriously, and then we went in and tried to deal with those before we stepped forward. The nitty-gritty issues I'm not going to bore you too much with, but really simple things that will have already jumped into your heads. What happens to that, the pension of the nurse that's transferred to the council, and will they ever get another job? What's the social worker's professional leadership when the chief social work officer role is sitting within the council? These sorts of things were things that people were asking us about. IT systems 4 years on, we've still not sorted out, just in case you think I have, so that's still a problem. But actually looking at how can you cut through some of the things that people were saying were going to be difficult, and even I see it's not on there, but under the professional leadership, professional indemnity was a really important thing, and we have that, of course, in health systems. When we transferred health staff to the council, they had completely different insurance arrangements which didn't actually cover. We have something called C. Norris in Scotland, which is a risk sharing, if you like, for indemnity, and suddenly we found 2 days before we were about to transfer staff, they may not have any cover. And in fact, the Scottish Government stepped in there for us and provided that brokerage so that that problem was resolved until we could do it formally. So all of these things were difficult. But on March 2012, we actually signed it. Now, this is Alistair. I've never seen him look so happy in his life as signing that piece of paper and passing me all his worldly problems and skipping out of the room straight after. But it was the right thing to do. It was absolutely the right thing to do. And I've described, it was seen by the staff, and we had to do a huge amount of work with social care staff, including writing to them all, doing CDs that we sent to people, having our own staff out talking to people about this being a merger. And in fact, we believed, and it's proved to be the case, that actually this would be truly impacting on every part of the system. This wasn't just going to impact on the adult social care staff. So day one, I'm lying in my bed, it was a Sunday, I'm thinking, oh, right, that's it, 1st of April, nothing happened, fantastic, everything quiet. Day two, Health and Safety Executive told us that they were going to go into one of the care homes we'd just taken over and potentially issue an improvement notice. Suddenly I'm going, okay, now I see what's accountability here, because now it's our care home, I'm accountable. Clearly this issue had been going on for some time, this wasn't a new issue, but suddenly we have to resolve it. And in fact, we never did get that improvement for that care home, because on day one, day two, which was a Monday, we sent our whole team into this care home, including the moving and handling team, the tissue viability team, the infection control team, wow, straight into this team. And the care home didn't know what had hit it. Okay, they were, wow, but they had the support that they needed, and we managed to turn that round. Now, we had never been asked for support before for some of these care homes. And we could have been, but we didn't. It was just interesting that we changed that. So we didn't get the improvement notice. But probably, and that was the beginning of the month, don't forget, come the end of the month, that was the biggest worry to me. I'd now got another couple of thousand staff and everybody needed to get paid, so that worked for us. So we're going to break in a second, but I just want to leave you with a couple of thoughts to set us up for going into after the break. We've now got health and care together. We've got the third sector important, and now we're trying to think about how do we co-produce services for the future. And the downward cycle that we found then Dennis in earlier on, where potentially either there's some medical situation that occurs, or in this purple box he's losing confidence and unable to cope. He comes into a hospital, maybe unnecessarily, might have something wrong, make him better, that would be fantastic, but because actually sometimes we're applying our own sets of values and expectations to individuals, I describe that as maybe institutionalized through care and kindness, where people will say, and if I give you the example of the crofter that's lived for the last 50 years with no hot running water in his croft up a strath somewhere in Highland, actually we've got staff that are assessing that person saying, no, that's not right, he can't possibly go home because there's no hot running water, and actually he needs a hot shower every day. And you know what? That's not what he needed. So we needed to think about what does the individual want. That has to be right at the centre, and to break out from this downward spiral that in part, not all of it, but in part, we're creating ourselves. Because Dr. Finlay used to save us in the Highlands a lot of the time, and we'll break there because Dr. Finlay is no longer around, I'm afraid, to do what they maybe used to do in the past. So it's 15:15. I've put this in to remind me to have a break. So we're going to take 15 minutes, if that's okay. I think there'll be some coffee out the way here. Enjoy your Tunnocks tea cakes. We'll come back together at past, if that's okay. Okay. So welcome back. Again, I've promised that we will definitely finish by 1 o'clock, so I will work my way through the rest of the presentation. Got one other thing maybe for you to talk about around the table. I'm going to just switch tack a little bit to talk about the context of change, and our quality improvement advisors in the room might pick up on some of this as well, because I want to talk first and foremost about quality, and then I will come back to what's been the impact of the integrated care. So let's just start again and realign ourselves with the Highland quality approach. So this is, we would see this branding around my organisation. This is actually, and we had to change it of course, because at the top of the triangle you can see it now says every person. When we first developed this triangle and we were a health board, it said every patient. So we've now had to think quite differently about the way we use some of these tools. But this is what we would be looking at, and this was really important for us to embed across the organisation what we've described as the Highland quality approach. And it's often hard with these things to say, well, what is that? And it really is the spirit then of how we want to improve care and outcomes for people. And your last speaker, when you last met with him, described actually that culture was the way that we do things around here. And that absolutely is what the Highland quality approach is all about. It's the way we do things here in Highland, based on, as I've described to you already, the IHI triple aims. But this is about the soft side as well as the performance measures and the hard-edged part of it. And I'd recommend to you the King's Fund document that's just been written on NUCA. And we had the fantastic opportunity to bring colleagues over from Alaska, from South Central Foundation, to spend a bit of time with us in Highland. And I did that in part through frustration, because a lot of people were saying to me, well, we're really remote and rural, and it's really difficult, and that couldn't possibly work up here. And the Alaskans came over, and they are fantastically humble people, very culturally aware, very thoughtful, and NUCA is something which, again, we would love to try and epitomise. But they took my 100 miles and they laughed at me and gave me 1,000 miles back straight away and said, this is what we have to do, and it's dark half of the time in parts of our area. So that unblocked some of the ways we were thinking. And it also, the South Central Foundation and NUCA is all about putting people right at the centre and actually having people not even just as customers but co-workers, co-participants in care. So for example, Steve, one of the GPs and one of the directors there, carries a massive portfolio of patients, but every single one of his patients has his personal cell phone number. And they don't have an out-of-hours service as such in Alaska because people don't tend to use it because they know Steve's busy most of the time, don't want to disturb him in the night unless it's absolutely necessary, know what the systems are for getting into the healthcare system if they need to. And Steve knows all of those people, and Steve has made sure all of the people trust the team he works with. So they get very proactive, appropriate care from the whole team. That feels like the philosophy that we would want to be trying to create. So have a look at the NUCA stuff if you get a chance. So for me, it's all about how are we going to shift the cultural barriers and the boundaries. It's about, and we've touched on it a couple of times this morning, a shift in power, a change in attitude for us as health and care providers, but also for individuals, for carers, for their families, and possibly some of our politicians as well. So it's the context that's really important here. So we're focused in Scotland. You have, as I absolutely know, your own quality strategy, but the ambitions in the Scottish one is around safe and person-centred effective care. So I don't think anybody would not want to do that. We have audacious view that we want to be world quality leading in healthcare, which is absolutely what we want to do in Highland. And we spent quite a lot of time saying, how could you improve care? How could you take waste, harm and variation out of your systems? And this is in parallel to our integration work. So this is not, I've been talking up to now about the what we did, this is a bit about how we did some of that. And we worked, first of all, we were asked to have a lean strategic partner. So using lean methodology, and GE were the partner we worked with for a short time, but they taught us the tools and techniques which were fine. And we had some good impacts in small areas, so we redesigned our wheelchair service, but it didn't actually get the traction that we expected it to get. So we started looking at other ways of doing things. This is, again, another element of our work. It's a Scottish Patient Safety Programme. I was doing this 11, 12 years ago down here south of the border, where there are bundles of care that need to be implemented, probably most familiar with the ventilator-acquired pneumonias in ITU, for example, where there's a bundle that if you apply, you absolutely know the outcomes that you'll get. So standardizing approaches, taking out variation and measuring things, again, is part of the philosophy to make sure you can prove the impact that you're having. You're not basing it on anecdote, you're actually basing it on fact. And we went over, we had a fellow that spent a year out in Boston at IHI, and that was really helpful for us to make some of the links, because although we're in the UK and we're in Highland, we do feel a little bit disconnected. So we were trying to link in across the world with organisations that were doing similar things to us. And the next sheet is actually in Boston. We sat with a serviette because we didn't have a piece of paper, and we drew out, myself and my director of quality, on a serviette what it was that we thought we needed to do. And actually we've come back and managed to do a lot of that, but you can see having quality at the centre is critical to everything that we wanted to do. Lots of change agents, having people reporting out what they were doing, but having bold and audacious challenges that we set ourselves. And again, I put this up purely to show you that it doesn't have to be something that's a 50-page shiny glossy plan. It can be something as simple as a serviette that you're really inspired to capture. So we, from our visit to IHI, met colleagues from Virginia Mason in Seattle, and I'm sure some of you will be familiar with this organisation. They had taken the purest Toyota concepts of lean and had worked with Boeing and now developed those into a methodology to apply specifically to healthcare. And we were really interested in that. You will have seen, I'm sure some of you will know that they were doing that with what was then the Strategic Health Authority in the northeast of England, with some success. So we went and sent a few people. In fact, I sent 3 clinicians. All 3 were doctors at the time. My very, very cynical medical director, a bright-eyed, bushy-tailed GP, and another associate medical director went out to have a look at what was happening in Virginia Mason. And was it all that they said it was cracked up to be, or was it actually all just another shiny thing that somebody had done? And they came back and said, blown away. Absolutely blown away. This was something that was embedded right through the organisation. And my medical director, who has since left me, retired, but he was so cynical. He even went back into the hospital at about 11 o'clock at night to see if he could find somebody who really didn't say what everybody else was saying in Virginia Mason. And he came across a chap who was a porter who absolutely said, that's what we're doing. This is absolutely embedded within Virginia Mason, and this guy happened to be a chap from Bewley in Highland, which is very close to where we stay. And so we now quite often talk about the Bewley porter mentality and how actually if you can get to the people right at the front, you know you've got it embedded. So we realised that the work we'd done with GE actually wasn't getting any traction, and we needed to work with somebody who had done it to find out actually how you could embed it. And the first thing we learned is you needed to develop capability in the tools and techniques. And all of the evidence now shows that, to be honest, it doesn't really matter what methodology you choose, but you need to choose one and stick with it. That's the important thing. You need to have that leadership from sticking with something rather than keep coming out with a new fancy thing this year and then you all run across and do something new and exciting next year and people just try and ignore it because hopefully you'll go away till next year again. So having something which you really embed was critical for us, and we chose to use a lean methodology. So we worked with we sent some people over to be trained as lean leaders. We actually work with North East Transformation System and found some expertise in Tees-Escombe Weir Valley, which is a health trust in the North East, where we started to develop capability and capacity. And now, and in fact this needs slightly updating, but now 8 out of the 9 directors, including myself, are qualified lean leaders. We've got senior managers embedded. They all are able to run rapid process improvement workshops. And actually, every single one of those improvement workshops can give you benefits that are sustained over time. And so going back to the serviette, we wanted something that gave you feedback immediately, 30, 60, 90, and now a year on, we go back to these pieces of work to see whether we've still got the traction. And we found, although Virginia Mason are working primarily in a health environment, in a hospital environment, what we've been able to do is to pick up this methodology and take it into any environment where there is a process. You can bring people together to look at how you can improve. And I know my colleagues who are sitting here as quality improvement advisors will be music to your ears, but that's absolutely what we needed to be doing, is getting people involved at the front line with changing the place that they work rather than having something done to them. It's really important they have that ownership. So we've got some high-level value students. We have issues in patient flow, as you can imagine, and we focus some of our quality improvement work that Virginia Mason and now we describe as inch wide and mile deep. You have to jump in really deeply and really understand what's happening, because what, as senior leaders, you'll be being told is happening actually isn't quite what really is happening, ever. So get out of your offices, go and see it, stand quietly and watch it, and you will find out what is really happening. And you can find out, I can assure you, more in half a day of watching quietly than you can from the last dozen meetings that you went to. So I know we all know that, but just think on about how much you really do that. So my directors now have to go out on the Gemba every week. They have to. In fact, now I don't even force them. They want to, because they know what they get from it. So this is just an example of happened to be one I was involved in, an oncology rapid process improvement workshop. I could have picked dozens of examples that we've run, but this one We started with an oncology rapid process improvement workshop because there were pressures on waiting times in oncology. We very quickly recognised the biggest pressure for us was actually in breast work in oncology. We narrowed down the scope, and then we found that it wasn't even just the part of breast oncology, it was the planning part of breast oncology that was the hold-up, and that was because we'd done about 12 weeks observations, standing in the department, actually seeing what was happening. We do use the data, but we absolutely go in and check the data with what people are really telling us that's happened. And we managed to decimate the wait times in breast oncology within a week, and that still has to date still been sustained, and that's almost 2 years on. It doesn't mean that we don't have to go back and do lung cancer or something else. So this is not a quick fix. But what it did was it taught the whole team in oncology about process mapping, flow, taking out waste out of the system. And we describe waste very much as the burden of work on people. So where our resources are tied up at the moment is in people trying to work their way through the systems, and GPs often tell me this. They help people navigate their ways through our complex systems, when in fact that is a burden of work and time that they could well be using to sort out the more complex clinical problems. So let's try and take out some of that burden of work. And very practical things. This is my very proud charge nurse in outpatients with her nursing auxiliary, who has Kanbaned the whole of their stock in outpatients. And okay, you wouldn't think necessarily reducing the cost by £500 a month in outpatients was a very big deal, but for her it was a huge big deal. And if you just multiply that up by every single store cupboard in every single ward in every single hospital, suddenly you're talking about a huge amount of waste that is not adding any value to our patients, our clients, our customers. So actually it's a methodology which is very simple, it's very engaging, but it actually has huge impacts very quickly for people and is easily taught. One of our guys went down from the medical receiving ward and saw what they'd done here, and within 24 hours he was back into medical receiving and had completely reconfigured their cupboards with these are 2-box systems where once the first box is empty there's a discipline that you have to send a card off to get that filled and the second box is pulled in. He replicated that in the high dependency part of medical receiving. And immediately when somebody came in with chest pain, all of that, the equipment that they needed was there, and the next box was being readily made up as they swapped it over for the next patient. So there's a quality and an avoiding harm element to this as well as just a savings. I wanted to touch then, again, another element of our work is around, and what inspired me was the work that John Cotter's done over years. Again, you'll be very familiar with this, I'm sure, but he described what made improvement programs work, and having that board level support is really crucial. And this was early work of John Cotter, and he wanted to try and get you to have that consistency, that clarity, people buying in to what you were all trying to do. So there was a common aim again, and that was something we were working our way up these 8 successful steps to change that John Cotter described, and we'd got a bit of a way up and we were doing okay, so we thought we were empowering people, we thought we'd got some short-term wins, but I started to struggle with this, thinking, hang on, it's not quite as, we haven't quite got the traction that we wanted. And the most recent book that John Cotter's written, I would absolutely commend to you. It's called Accelerate, and what John Cotter then has recognised with his team is that in any big complex organisation, this hierarchy on the right-hand side crushes out the creativity and the innovation from teams who actually know what they want to do, but because in order to get to me, they have to come through 8 million people and 3 boards and all of the papers that go with it, and it's really easy in this hierarchy to say, yes, go and do a business case and we'll see it in 3 months, and then 3 months later we might look at it. And that kills people. It absolutely was killing people in my organisation. So they were waiting for somebody to do the business case. Whereas actually, if you start a business and you're excited and you're creative and you're innovative and you bring interested people around you, as Cotter describes on the left-hand side here, then immediately people start solving problems. And that's for us what the lean, rapid process improvement weeks do, but it also allows a link, and his real master thought was this dual operating organisation means that you can't have a £750 million business that doesn't have a structure and a hierarchy. But you need to link people in so that you don't kill the creativity and have people, if there's something which is a really wicked problem, don't get all the most senior people in to talk about it. Get the people who are really dealing with it and say, hey, on you go, sort it out. And let them try and have a go at sorting that out with your support. You keep the link into the hierarchy, so you keep a clarity about vision. They know what they can't do, but they also can actually get on and do some of that. And you in this room today have a critical role in being able to encourage people, I would say, to go out and do that. So the important thing is having a golden thread through for folk then, having something that takes, what am I doing down here on the right-hand side? What are my individual objectives? Where am I putting my effort and my time? And what is that triangle saying at the top? So that's partly a 10-year plan that we have to fit in with the Scottish Government's strategy. We then decided that this year we needed to turn those into annual goals for people. And working with Virginia Mason, we realised that actually there was a big disconnect here. That golden thread was not clear for folk. And in order to actually put your efforts in the right place, you need to know what the organisation is trying to do, what the context is, and how you can then internalise that for what you're doing. So we've now in a process, and we're in this process now, so this is brand new work that we're doing, which is called Catchball, which is saying to people, okay, these are the things we think that we need to do as an organisation, and these are our organisational priorities. We're right up here, all of us are thinking big, important things, and then we're taking them out through tiers of staff to catchball them and have a conversation with them about what they think. Are they the things that resonate with them? Before, on the 1st of April, we publish our set of objectives that then people will have team objectives and personal objectives for. But let me show you what a difference it's made. So the first one that we wrote then, and this is me and my team sitting looking at workforce. So we had some real problems with costs for locums in Highland at the moment while we're reconfiguring the staff. So we wrote this as our set of workforce objectives to reduce the current dependency on temporary and additional supplementary staff. And the first iteration of this said reduce the cost of locums. Okay, so you get where I'm coming from. They were quite straightforward, very practical things. And then we wanted people to be aware, and then we wanted this percentage of staff, because we thought we'd better make them measurable, okay? So increase the percentage of staff to reflect those objectives. Aren't we clever? Out we went to Catchball. So we're confident people are going to go, you're our leaders, you're fantastic. They trashed us. They completely trashed us. They came back and said, why are you calling it workforce and not people? Why are you talking about actually reducing the costs, which is what we want to do, but why don't you say that NHS Highland should be the place where everybody wants to come and work? Which is a much nicer way of saying we want to reduce our costs on locums. Making sure that staff were proud of their contribution was just a fantastic thing for people to say, which was what we wanted, but we hadn't really put it in those sorts of words. And most importantly here, about making staff feel engaged as part and valued as part of the team. So can you get my sense of how that's so different when you're actually going out on the front line, describing it to people, letting them have a chance to come back, and not being precious over that, well, I know you're saying that, but we wrote this. So we like this, still going through it, may change a little bit, but now we've done it a few times with a few groups of staff, it's less, there are less changes coming through. The quality ones were about looking at people in a completely different way, using modern technology. Again, they've changed the wording on this so it feels more person-centred, and appropriate clinical care was engaging with people, but it may not just be clinical care we were talking about here. And the final one of care that we put in, and this is our third element, I really like, because we had minimised the number of delayed discharges, and that just brings us back to Dennis and starts where we started the conversation earlier. And in fact, a really good team said to me, this is about stopping people being away from their families. And that is such a more engaging and empowering way to look at something than delayed discharges or bed blockers. So these are the things we're going to be saying to our staff. That's what we would like you to do. Now, what are you going to contribute to these objectives? And even maybe somebody in our finance department can't directly prevent somebody from falling, but I bet in the community they live, or their own parents or somebody, they could think about preventing from falling. So it's more holistic. It feels more engaging. And I was just sharing that with you because we found really interesting feedback. We were quite surprised, and we thought we had staff engaged, but actually nowhere near doing catchball was really important. So the values, again, are important to us, and I'm going to just, I think we've got time just to pause for a minute to do another very short piece of table work. So if you'd like to, on your tables, turn over the, there's a sheet that looks like this on your table, and you need to be able to all see it. So if you put that where you could see it on the table, and there should be a tiny, maybe a white or a brown envelope on the table as well. That's yours, is there. And it's got half a dozen cards in it, okay? So this is only going to take us 15 minutes or so, but if you can pull out those cards, and we'll put those, nobody ever does this properly, ever, because you never, ever, ever follow the rules, but nevertheless, I'll do my best to give you the rules. This is a pyramid of values, and the little cards that you've got are actually, they could be yours, but they happen to be our principles of NHS Highland. So actually it came from the Improvement and Co-Production Plan for NHS Highland. And what I want you to do on this pyramid is to take one of the cards, and you generally lay them face down to start off with, but again, you never end up with them face down after about 5 minutes, but that's the rules. The first person then takes one of the cards, reads what's on the card, and places it on the pyramid where they think it is of worthlessness or of most importance. I think those are the two ends, am I right? Something like that? Yep. Okay. So you put that card where you think it should be on there, okay? Then your colleague to your left or right will then take the next card, and they will either move your card and put theirs on, and they have to say why, or they put their card somewhere else. Have you got the rules? You have to do it with all the cards. There is a refrigerator, I think, on there. If you get caught up discussing it and you're going cold, put it in the box and ignore it for a minute. Move on to the next card. There is a trash can if you think that any of those principles are of no value whatsoever or no importance. You got it? Right, 15 minutes, go. Okay, so how are we doing? I'm going to break up the fights now, if I possibly can. How are you doing? Coming to a conclusion? The truth is, of course, there probably isn't going to be a conclusion for you, because there isn't a final da-da. This is all about the conversations that you've been having from the different perspectives. What, though, out of interest, do you have at the top of the triangle? Person-centred? Yeah. Person-centred all around the room? Yeah? Yeah? And safe? Okay, so a lot of similarity then, and that's really interesting for us. If we can get to be focused on the person, that's a really good basis then for all of the other discussions. And genuinely, we've done this and we still argue about this within teams, but it's a very engaging tool to help teams of people who come from different perspectives to feel safe to have a conversation. The critical thing is, what are the things you're trying to put in the boxes? And they need to be yours, but the conversations that you've had, and I could hear you having, even here, were very rich. And those were about our principles. Imagine how rich those would be if they were your principles. And a bit more heated if you'd written some of those, okay? So I share that with you just as a tool for you to think about using in your own teams, and it works right through organisations, but you have to have a safe environment where people are happy to share their views in a really constructive way. So I'll leave that with you. So let's move on. I've left you my photo up there of my Hogmanay, where I was stood on the deck in my house with a glass of champagne as the bells rang. And the aurora came out just to light up the Scottish Highlands. So isn't that beautiful? It's the benefits of living with a photographer, I would say. So, back to health and social care integration, because I wanted to just give you some feedback on what actually happens. So, I've given you the background to integration. I've now given you a context of quality improvement that we use not just in adult health and social care integration, but in all of our services. But wanted to give you some feedback then of what actually happens. So here we go back now to year one. We're post-integration. And one of the important things that actually the values pyramid brings out and happened to us for the whole of the first year was that people don't really understand each other's business. They say they understand it. They might say they know what a social worker does, or they might say or think they know what happens in an acute hospital. But in all honesty, unless they've touched it and felt it or worked in it, it's very difficult for people to genuinely understand other people's businesses. And so the first thing that we had to do was try and get people, because we now had social work managers managing whole teams of integrated staff, including obviously care at home and health workers, and we had health managers managing whole teams of social care and care at home staff as well. So that was a really important lesson, and if I had my time over, I would have spent more time making sure people from different parts of the business had gone and seen, touched, felt and understood the other parts of the business. You can never start doing that too early. So we spent a lot of time making sure the services that we had inherited were safe and high quality, and that we had all of the systems in place that we needed to do for the regulators, for example. I've added at the bottom, slightly tongue-in-cheek, but one of the things that hadn't happened for us for years, all the years that I'd been there, was that social workers all went on holiday over Christmas, and hardly any of them were available until quite a long time after the new year. Our social workers all worked that Christmas. They weren't happy, but they realised that that was one of the benefits to us of integrated care, was that the whole team needed to be there for that point of time when we were going to have the system under the biggest pressure. So we've got, I already described I think a little, but I've just put in some photos because I wanted to bring it to life for you really. So this is a virtual ward team with the charge nurse there leading the team in the centre in Invergordon. Geriatrician, that's Martin at the bottom on the left-hand side there. And they're actually working through a number of patients that they have, all carrying on their caseload, but they're actually now going through them as if they were in the room as a ward round. So it's a very formal process, but they make sure that everybody knows what's happening in their patch with all the people. So again, I'm not teaching you anything you don't know. I'm sure you've got plenty of these going on, but these were people with the social workers around the table and then moving on to care workers around the table. We hadn't ever got them involved in our truly virtual wards or our multidisciplinary team. And the care at home, I'd underestimated where our problems might be. I thought that our biggest problems may be in care homes. In fact, our biggest problems were with care at home. We had a private provider that actually wasn't meeting the standards that we required, or in fact they were contracted for, that we took them out very quickly and replaced them with our own teams and started to provide care in a very different way, giving now generic health and social care workers qualifications so that we could bring the standard up and in fact make the sector more attractive to people. Because there is still a stigma there, there's still a feeling that actually it's better to go and pack shelves in Tesco than it is to be a care worker, because actually you're just looking after grannies, whereas in fact this is critical, very important work that we want to reward and support and encourage as a sector. And of course people would look at healthcare workers in hospitals and say that's an important job, but they wouldn't think that a care worker going to somebody's home was an important job. So we've tried to turn that round and make that really important. And this lady took me out on her round in the morning and came to pick me up she said, oh, I'll pick you up at 9 o'clock. And I thought, God, 9 o'clock, do they only start at 9? That's ridiculous. And she said, no, we start at 6:30, but we know you won't be until 9. So I'm there at 6:30 with her, and we do her tour. I am humbled by what I see. She is just the most compassionate person in the work that she's doing. It's fantastic to see. And there's a place where we park, and she provides care to this client, and then we get back in her car. I tell her what great things she's done, and we drive right the way to the other side of Inverness, where she tries to get a lady, and she's telling me as we go up the stairs, this lady won't have a bath, definitely won't have a bath. Every day I fight with her about having a bath. She only wants to have a bath 1 day a week. So don't be surprised when I have the argument with her because the care plan says she has to have the bath. So sure enough, we have the row about the bath, and she doesn't have it, and she has to write down. And I said, do you think she might not want the bath every day? Possibly. And the girl said, oh yeah, I've been saying that. Yeah, I've been saying she doesn't want the bath. But of course, if she doesn't have the bath on her care plan, then she might lose that bath when she needs it later on, and therefore we have to do it you have to have this argument with her every day. Well, do you know what? When I'm 90, don't be putting me in a bath every day. Thank you very much. So I'm describing that because I would never have found that out had I not been there with that girl on the Gemba, talking to her and seeing what she was doing. She knew that was ridiculous, but she had no power to change it. So we started talking to care workers in a very, very different way. And incidentally, after we finished that lady, we drove back, and guess what? We drove back to the car park next to the car parking space she left an hour before, because her next call was the next door but one person that she'd seen an hour. Now, what was that all about? 20 minutes drive over here, and then she had to come back. She could see that was silly. We've now got our system zoned. We have people working completely different ways because there was waste in the system, which was taking crucial time away from direct client contact time. And that's what we needed to focus on. We're in our houses as well now. We're putting technology into everybody's houses that we possibly can, but be careful, because we've recognised that, particularly in remote rural areas, it's great to have the technology, but actually you need the socialisation. You can feel very isolated, all of the issues that come with that. So yes, use the technology so you can maybe redirect your services, but don't make these things that are boxes on the wall that people don't get any human contact at all. So just a word of caution there. So now we're into year 2. We've now started moving people gently into buildings. So they're now co-located. We've changed the role of care homes now. We've been looking at care at home in a very different way, as I've been describing. And we've started bringing quality conversations into everything that we do in health and care. So yes, there's a focus on individual outcomes and performance, but we wanted people to be absolutely clear this was about the individual. And we reviewed every single person in Highland that had been getting any sort of care support from us or the council prior to us. And this might just look like a very boring allocation of resources meeting that happens no doubt all over the place. But in fact, what was happening here is suddenly, by putting everybody together, including our private providers, we were able to maximise capacity by saying, do you know what, it's not about the contracts. This isn't a contracting discussion. There's another place where we have the contracting discussion. This is about us all saying, who can take this person? How quickly can you do it? Why can't you do it tomorrow? Who can you work with in the sector that's going to be able to provide support for this person at home? And again, suddenly doors opened and people started working in a very, very different way, because we guaranteed that we weren't going to reduce their income or their work, but what we wanted to do is to maximise the capacity that we'd got. Just wanted to touch on a care coordinator, and she wouldn't look at the camera, she was far too shy, but this girl is worth her weight in gold. And this is the Tain Centre, where we've now got care coordinators, a single phone number for a single point of access in every single one of our 9 districts. And that can be contacted by care providers, by families, by individuals. And she will log those but redirect whatever the individual's query is. Sometimes she can deal with it herself, but she is the absolute link between all of the services. So these are crucial people, because it could be a care issue, it could actually be a housing issue. We don't manage housing, but whatever the issues are, there's a single point of contact now where we can link in with the in hours and the out of hours services for people, and it's much, much more joined up. And we stole this from Torbay. It was not our idea. We were so hung up ourselves on the role of a care manager and a case manager. Have you been there? Have you got that t-shirt? So that one, you know, oh, well, I can't do it because I'm a case manager and I'm quite important, and over here I'm managing a care. And this person is, I think she's a grade 4, maybe 3 or 4 administrative person that actually coordinates what everybody else in the MDT says they're going to do. So she chases what's happening and makes sure, as well as directing, chases people. And they'll have this is GP here with the team in a morning community huddle, so they'll do that every day. What are the issues? What are the issues overnight? What's happened to that person? Do we know what's going on? What are they telling us from the list that we need to do today? And what we're trying to do is to keep people as close to home as we possibly can. Going back to that circle I was showing you earlier, trying to prevent that downward spiral for people by keeping people, as if that is what they wish, as long as they wish, as close to home, and ideally to die at hospital if that is what they would like. So year 3 then, we further integrated care at home. We started then bringing in, because we realised that although care at home workers were going into the homes, we weren't maximising some of the information those care at home workers were actually picking up, because then the other people went into the home 2 hours later. So bringing the care at home workers and putting them into an integrated local team of district nurses and AHPs and social care workers, actually suddenly you got more value from the team that you'd got. So again, they feel quite important now. These care at home workers probably are closer to and know more about what's really going on than a lot of the rest of the teams that are going in at different times. So we've tried then to combine that whole system and redesign things, and we've been doing reasonably well with that. We want to see more use of care homes that were, I would say, quite traditional, quite blocked. When you went to a care home, you weren't coming out from there ever, and we hadn't really got the step up, step down opportunity and facilities, and until some of our district nurses said to us, you know, even in a care home, if we had not just some respite beds, but if you gave us a couple of beds where we could manage people maybe at the end of life, or they could do a huge amount more. And of course the care homes now are run by NHS Highland, so we had that opportunity to be able to do that. And day centres is still a bone of contention for us. So we like day centres, we think that's interesting and people like it, and again it socialises people, but we found that in our day centres we had people that were becoming almost pet clients that were coming in for years into these environments, and they had a lovely time, but what we weren't doing is saying, how can we actually help support you to get you into your own community? So you don't have to come to ours, we're just a stepping stone for you to go to your own community. What is it about community resilience, local responsibility? How can we work now with the third sector, other people, to provide care to the people in their local communities? And that's proving tricky, but we're getting there with some of those concepts. So I've touched on the single point of access, and I'll just put this up about Pulteney House, because this is a care home. Looks quite austere from the outside. It's up in the very north coast in Wick, and when I went into they've got a beautiful view across the sea, and this is in their conservatory, and there was this fancy computer sitting there, and I said, so okay, so what do we use this for? And I thought they probably used it for Skyping and contacting, and sure enough they did. But they told me that very day they had not only Skyped into Australia on a personal level for a client in the care home, but they'd done a full assessment with the team here, with her daughter at the other end, absolutely seeing what we were doing. And you thought, that's fantastic, isn't it? You know, they are absolutely using and maximising the technology. as it happened a few months later, this very same team broke every rule that there possibly could have been in the book by allowing a travelling family whose grandmother was dying, and they knew she was dying in this very care home, some of that travelling family to stay with supervision in the care home, because, as you know, traditionally they wouldn't want to leave their family at all. And for that work they managed to achieve a Highland Quality Award. So we do try and reward people and give them something which says, actually, that's a fantastic thing, over and above what you would normally do. And whilst they like to have it, what we didn't recognise is that our care inspectorate took the achievement of their Highland Quality Award into their assessment and their evaluation, and they scored straight 5s in all of that care home because of the work that they were able to do. So I think recognising really good, outstanding achievements is an important thing, and I don't think we do that well enough, often enough, but there are very easy and very cheap ways that you can acknowledge that. So I've touched a little bit on community resilience, and this really is the post office down the road from my house, so don't you laugh now, thank you. This is a post office. You have to knock on the lady's door over the road, so because she's got the key to the post office, but you can send a letter or a parcel there. And that shows you that you can be really creative about community resilience. And of course, we will be retiring, hopefully, and there'll be lots of people, because of the great work we've been doing in health and care, that have more years of quality life available in retirement. And it's us that we want to be able to contribute something back to the communities. So whilst this is a practical example, actually having people doing more things for themselves and for each other is something which we've possibly lost the spirit of, and we need to try and reinvigorate. And that's partly because as institutions, I think, we've become quite paternalistic. We've told everybody for years, don't you worry, we'll sort that out for you. And actually we're not going to be able to do that forever in the future. So working with the third and voluntary sector is important. This is dementia friendly community out in Sutherland, where actually everybody has got behind this initiative from Alzheimer's Scotland, where they understand dementia. They are happy to support dementia. We've taught them about dementia, and in fact they're openly embracing people in the communities with dementia. So somebody who has one of their loved ones is no longer frightened or worried about going to the hairdresser, because do you know what? They know what the issues are. They understand what that is. They welcome that in. And the school children are in there as well, actually working and educating other people. So get them young, get them involved, get them to understand what older people need. And that the buzz you get in the room when you have older people sharing experiences with young people is absolutely fantastic. Telford Centre is another care home that we have somewhere down the by Fort William in Highland, and unfortunately about 2 months ago maybe now, the local GP practice burnt down. That was very unfortunate. It was the electrical fault, nobody was hurt, it was all fine, happened at the weekend. They even had a disaster recovery for their records by some astonishing, amazing miracle, but anyway they did. But they now have no space. And what they did, because now we were working all together, realised that, well, here's a fantastic centre of the community care home that actually did have some space in it. And our GP practice now today is running out of this centre. And we probably wouldn't have even thought about doing it. We wouldn't have even talked to them, let alone asked if we could go and move in. So now people are actually thinking, you know, maybe we don't need to build another doctor's practice here. Maybe actually this is quite a helpful thing to do. So it was an opportunity that we hadn't anticipated, but has been really helpful, I think, for us. And I bought a copy of this book today because, and if you haven't seen it, again, I'm making you buy books. I'm not on commission for anybody that thinks I might be, but if you don't buy the other one, do get hold of this one, because I was driving somewhere, as you often do in the Highlands, listening to Atul Gawande do the Wreath lectures. I think it was last December. They are still on podcast, but Atul Gawande, if you don't know him, is a surgeon from Brigham in Boston, and he's now taken to thinking about end-of-life care, and it was very much what we were talking about everybody is going to die. So why aren't we talking about that? Why aren't we preparing for that? Why aren't we thinking differently about that? And when is something palliative care or end-of-life care? And what are the different things we might do or we might want to do? And how can we help people to have different conversations when they're nearing the ends of their lives, which allow people to maximise the quality of their life for that time that they have left? Because we do still often try and jump in and do heroic medicine, and we do it for all the right reasons. I'm absolutely not being critical, but having this book and sending some of my clinical colleagues to listen to the podcast has changed the conversation we've been having about the sorts of services we might want to provide and we might want for ourselves. So I would encourage you to have a look at it and see what that might do to your health and care system, because 50% of people in Highland die in hospital, yet not 50% would want to. Now, some need to, but not all want to. And so what are we doing to try and stop people being caught up in our hospital system that now we've got them in it, and Dennis was there a couple of times, and we weren't going to let him out. Yet we knew he was going to die. So I've been impressed with this. You might like to have a look at it ourselves. And one of our initiatives on the back of Atul Gawande's work is My Home Life, where we have, there's a fantastic chapter in there about a very innovative, was I think a hospital doctor, went in to be what we would describe as a GP, but then started running a care home and realised that some of these care homes were without life. They were drab, they were quiet, they were uninspiring, the sorts of places none of us would want to be. And so we've turned that on our head now, and our care homes are quite fun. They do lots of things which we have to have care plans for the dogs and the cats, and this was quite vicious, this cat. It liked some people, but it didn't particularly like me. But going in and seeing people happy to have cats and dogs sitting in the care homes, actually seeing, an old lady with a cat on her lap is just fantastic. So we've had to get around all of the things about quality and inspections, but we're working closely with the inspectors on these things because it's all about what really matters to the individual rather than the rules that we had in place. And I do remember when we first moved on, and I couldn't find the photo, unfortunately, when we first took over the care homes, I do remember going up one of our care home corridors and them trying to shimmy me backwards so I didn't notice there was a tiny dog that had run from one side of the corridor to another because they thought they shouldn't have dogs in there. So it's all about how can we change the environment. And we will need to think very, very different because actually frailty is going to be the important thing that we all need to deal with. Martin consistently tells me that we need to think frailty. We need to think about complex comorbid disease. We need to think about older people. And we need now, time is now to be preparing for the future. So last just couple of slides then about what we might think is the new care. Again, I'm sure this would resonate for you and with you. What I want is to be as independent as long as I possibly can be. Thank you. I'd like to be in my own home. I'd ideally like a box of chocolates one side and a large gin on the other side. If you could organise that in my care plan, that would be fantastic. I've told you I'm not going in the bath every day. So, what is it that would be good for you, and how can we make sure that actually people get the thing that they want? We shouldn't have people in our acute beds that don't need to be there. I am not saying we shouldn't have acute beds, because clearly if I need an acute bed, I want to get in one quickly, and I want you to do what you need to do to me to make me well as fast as possible. And we do a fantastic job of that. But there are plenty of people now in expensive hospital beds that not only do not need to be there, but are being compromised because of being there. So we need to do something about that. That is our responsibility, to do something about that. So coordinating the care, redirecting resources always feels a bit uncomfortable because, you know, clearly we haven't got enough money, have we? Well, I think we might have talked about that already. We've got quite a lot of money from our lean work tied up in things that aren't adding value to people. Our job's to unlock that, put it back out here to where we really do need it. So I don't have any notice given to the fact that we haven't got any money. Yes, I'd love more money, but if you doubled my budget, I could spend it. So how do we manage the resources that we've got most effectively? And we have to do that by working what the Alaskans would describe as at the top of your license, making sure everybody is adding value in the way that they can and that we're not precious. We do what I said to you at the beginning. The Highlanders tell me to get over themselves and actually think about care in a different way, which is absolutely maximising the use of skills and focused on the individual. Because this, if I have to leave you with something which is obvious to remember, the experience often for people is that, okay, if you need acute care, it's important and you get it, but actually it's a better experience for you if you can look after yourself. It's more expensive to have acute care unless you absolutely need it. So how can we make sure we balance this off and move further up that continuum so we can maintain independence? So the ingredients that we think are important to impact, and I need to say again, we haven't cracked this, okay? This is not, you know, this is not the final story. This is a journey that I'm sorry to tell you, you never come off, okay? You're continually looking for what you need to do next. And so we know that support from the board is important and consistency of message I've described as important. That organisational alignment is critical to what people need to do. And for us to get that embedded intensive training so that people were talking a common language has been very helpful for us. I've not talked today at all, and I do sometimes talk about a clinical compact. I've sort of touched on it, but having that agreement from clinicians about what are the gifts that the organisation will make for what are the gets they will have in return, and vice versa. That is a really important conversation to be having with people. And you need to celebrate success. Actually, getting people out, you underestimate, I'm sure, as leaders, how important people would think it was for you to give them your precious time. That accounts for a huge amount that you underestimate. Just to see you there, just to see you interested in what they're doing is really, really important to people. And it's much more exciting than sitting in your office doing emails. I can absolutely assure you of that. So do get out, but have that patience, have that nerve, and have that passion for continually wanting to improve. And the final message from me is absolutely you have to hold your nerve. This is not easy work. I commend you, all of you, for every day getting out of bed and coming and doing it again, because this is a tough world that we're in, but the opportunities are huge and there for the taking. So do hold your nerve. It would never be right of me not to thank my fantastic staff, and I do that at every opportunity. And thank you today for giving me the time to talk to you. So thank you very much. So be gentle with me. I'm happy to answer any questions that you have, and I'm here over lunch and have been invited to stay a little bit into the afternoon. So if you're too shy to ask me now, I'm around for a little while so that we can answer any questions that you might have, or I might not be able to answer them, and I'll tell you that. So who would like to ask anything or something? Or just through reflections, actually. So, all right, on you go, Tracy, and there's another one over here.
Hi.
Hi.
The question I want to ask is, you made a massive change, and budgets were reallocated, money moved on, and then you took quite a lot of people. The significant part of your work being successful was, one was influencing people, people who are in the front line who are working. Number two, convincing people who are probably clients. And number three, I thought was really innovative was NHS running care homes. How did you wrest it away from the private providers? We took over. I think we've got 15 now. I think we had one in private sector that we've taken over. So they came as part of the adult social care
package because they were being run by the local authority. So they moved to us the day 1st of April when they moved over. We suddenly had responsibility for all of those 15 care homes. And of course we had to re-register as the provider under the regulations, slightly different in Scotland, but the same sort of thing. So we were then accountable for everything that was being provided. So it was just part of the move across, and we very clearly didn't want to leave bits of the service still in the council. So.
But then the blurring of margins between providers and commission.
So there's no blurring at all. So the commissioners commissioned me to provide all of adult social care.
Okay.
And that includes however I want to do it. And that was the important thing. There is a commission, they commission us on outcomes, so they want to know what outcomes they're getting, but actually they weren't too worried, and nor should they have been, about whether I provide that in a care home or provide that in a care at home, or is it a nurse team, or so we inherited these care homes that were, as I've said, very traditional in the way they were working, and we decided that actually you could use those in a very different way, and that's what we've chosen to do. I challenge that you could do that yourselves now. Don't need to be integrated to do that. That's a conversation to be having.
Hi, I thought that your presentation was excellent.
Thank
a lot
you.
of things that we can learn from
Good.
what you've said. One of the things that struck me most was around that real value of the staff members out there doing the job, and about engaging them and them innovating and feeling that everyone adds value at all times. And I was just really interested in some of the ways that you went about that, because one of the issues that we're currently having in Norfolk is about we're on an integration journey, and we're finding it very difficult to almost release clinicians to get involved in developing some of what that integration is going to look like, just because of the real pressures on time and capacity. And so we've done things like had engagement sessions. Actually, people haven't been released to come along, they haven't worked. And so it was just, I obviously picked up on some of the things you were saying about actually maybe we go to them, and we have started to have that conversation. But it was just about, was that a tension as well for you? How did you get around some of that?
I think that's always a tension, is how do you engage people when they're already busy doing a really busy, difficult job. And I was actually asked this question at the King's Fund by a whole load of consultants a couple of weeks ago, and the bottom line is, if you can help people to see that actually the future is better than where they are at the moment, by painting that vision for the future, that catchball stuff I was describing, what our aspirations are, and saying to them, actually, you have to help change this because the future's in your hands. I can facilitate it, but I can't do it. So by saying to them, there could be a different future, but you have to participate. Therefore, if it's something they're interested in and excited about, they will give freely of their time, actually, or they will reprioritise the things that they think are important to them. If they're not coming, it's either because people are stopping them coming, or it's because actually they don't think you're going to make any difference. So why am I wasting my time? So if they thought they genuinely had an opportunity to shape the future, then they're likely to find the time to come. And you would love that Cotter book, because that talks all about how to release capacity, how to have people thinking in an innovative way, and how you can engage them to do things that again, I won't spoil the book for you, but there's a bit on, if you Google, I think it's Cotter International, I think it's on YouTube, if you Google it, there's a tiny piece of video clip on there where Cotter shows the hierarchy and where we are. And of course, I recognise myself straight away. Here we are, we have a problem, we're really busy. I know what we'll do. We'll go and buy some consultants in to come and help us sort it out. Okay, I suspect we've all done that. And what do the consultants go and do? Because they haven't got a clue, because they're consultants. They go and make those really busy people busier by interrupting them and saying, could you just tell me what you're doing? Because then I'm going to go and tell these big people over here in the room. Do you know what? The consultancy kills it. Just kills it. It's not value added. Okay? So when you see this hierarchy sinking under the waves in the video, you realise that probably we've got that wrong, and probably the solutions don't need to come from a consultant. They're probably right there in front of you, but you've got to release that. I am not saying it's easy to do. You know, we have a breakfast meeting for doctors. It's completely open to anybody. We'll be having one next week, I think, and they're at 7:30 in the morning. Okay, we have to tempt them with a bacon sandwich, but we now have had to go to a bigger room because they know I'm going to be there. They know other people that they're going to be able to influence are going to be there. So they come to hear what you're going to say and to influence you. I want them to influence me, so that's great. But it means I have to get out of my bed, and I'm a vegetarian, so I don't like the bacon sandwiches, but I get out of my bed to go with them. For the price of a bacon sandwich, we have a full room of clinicians, mostly who don't know each other, that immediately build up relationships with each other. Again, just tiny little practical things that, you know, you just need to think a bit more creatively, so good luck.
Thank you. I'm really interested in, you've made some huge changes to the whole strategy of delivery of care between adult services and paediatric services. Mm-hmm. And obviously there were specific drivers as to where those different services sat, and there were some very real decisions to be made. And I'm very interested in how you measure the outcomes of these huge pieces of strategy change. And that's really my question.
Yeah, okay, so the commissioners, and we commission the children's services, as I've said, we have a set of outcome measures. So there are, in Scotland, there are some specific, we call them heat targets, but they'll be your normal targets, the number of people with the delayed discharges, your acute waiting time. So there are balancing whole system measures that you would see as health measures. There are also then, and there used to be what the councils used to call key performance indicators under a single outcome agreement with our local community planning partnerships, and I haven't mentioned them at all today, but we brought together then in one place all of those outcome measures for adult social care, and we brought together all of the outcome measures for children's services, and we found most of them were rubbish. They weren't actually measuring what the people that were getting the services really needed to measure. Now, in adult social care, we had something like 130. You know, there's a huge number if you looked at them all. So over the last 4 years, we've been trying to drill down to those, take some of those out and say, what are the real critical balancing measures? So for us, for example, and I'm sure it's the same down here, our A&E wait time is a barometer of the flow in your system. So we could track things like our A&E wait times. And even now we have a daily huddle in all of our acute sector, but in our acute hospitals, we also have community staff in our acute huddle. Some of those are video conferenced in because of the differences. So everybody in my whole health system at 8:30 in the morning will know how that system is running. And therefore, they will know what they need to do in order to maintain the flow through the system. Now, we still have hiccups, but that is one of the key performance indicators now that we look at operationally, but also our commissioners are looking at to make sure that services are being provided in the way they've fundamentally commissioned them. Does that help?
I suppose my question is, how do you isolate the benefit of the big strategy changes against the sort of more locally delivered changes around values, leadership and organising services?
Okay, so we're quite relaxed about that, because what we do to a local team, and I've described we've got 9 district teams, we will say this is what we want, these are the outcomes that we want for people. So based on those commissioned outcomes, but also our strategy, so the objectives that I've shown you already. And again, we're not too worried how they do that. So the local teams will work together to decide how they're going to reconfigure. We've suggested, because we piloted it in 2 areas, that a single point of access was critical. So don't reinvent everything everywhere. If you know something that's working, then now try and spread that. But we had to have, and we described those in quality improvement language as those small cycles of change that you then can get right, and then you can embed, and then you can spread really quickly. And by having a management team, and I didn't mention the strategic and a structural change we made in 2016, well, it was just came in at the end of last year, is that we recognise that if integration worked for health and social care, why didn't it work for health and health better than it was at the moment? I think that's probably the nub of some of the question that you're asking me. And so we moved, when we had opportunistically our Director of Operations in our community organisation left, I brought together the whole team from the community and the acute hospital together as one operational team. And within 24 hours, they were having different conversations. And it sounds ridiculous. It sounds ridiculous because these were the same people that were still working together, 2 weeks before. But suddenly now they were saying, well, actually, it's all of our problem. So now how can we have a different conversation? Because the community team encompasses adult social care. And there's something in people's psyche about the silos that we get into. That this is my responsibility, but if it's just happening down there, it's nothing to do with me. So let me go back. I gave you an example of the nurses in Tain that wanted to use the care home for a step up, step down resource. Because I was out on the Gemba and was with those nurses, they described that to me. And I said, and I spend a lot of my time saying this, very Scottish phrase, it goes, on you go, okay? So I go around giving people permission by saying, on you go. Test it small, test it safe, but on you go. So I said, on you go to her, and she said, oh, can't do that, Elaine, no way. She said, because I've been to my manager, and my manager has said, actually, can't afford to do that. We've got no money. You've probably heard that. We've got no money, and therefore, it's not out of her budget. If the patient goes into the acute hospital over there, it's not out of her budget, so no, she can't invest in the care home. Now, again, that isn't the sort of care that we would want to provide, but I can understand when that poor manager is being, and you will be in those places, you're being beaten up by me from the top down saying, make sure we come in within resources, and here's an opportunity you've got not to spend any more money. That's a very attractive thing not to do. And in fact, it might even feel like it's the safe thing or the right thing to do. Step over here and look at it from the individual's perspective. That's not the right thing to do. And in fact, if you had an overall view, you would know that the chance of that person falling over in hospital or getting an infection or becoming debilitated and then ending up as a full-time resident in the care home was much more likely for the want of a small investment into the care homes. So we need to flatten that decision-making hierarchy so people can understand the implications and they don't feel lost and alone in carrying that responsibility, that burden of holding the budget and being shouted at by everybody. Those are the toughest jobs to do. Well, now I've made you look all glum. We're going to have to talk about puppies and kittens again, aren't we? And go on you go.
Again, thank you. You've just woken up a very tired brain this morning. It's fabulous. You've talked about it being bottom up, top down, a complete approach and permission to transform and innovate. How did you upskill your population of staff to be able to do that? How much time, education, what did you invest right the way down from your care workers, right the way through? You've talked about the top and your lean training and everything else, but I'm intrigued about the other end.
So from a purist quality improvement perspective, we had thousands of people in our organisation who'd been trained in quality improvement tools and techniques, and I dare say with all those productive series that we've stolen and used in Scotland, you will have the same. So there won't be many nurses in any of your organisations that aren't familiar with PDSA. They will all know it. Are they using it every day? No. So actually what this was about, we've invested a lot of money in quality improvement, science, methodology across our organisations, but we've never unlocked that capacity and that capability. And as improvement advisors, again, you have to be challenging on that. You have skills now. No point in just you being able to do it. You need to go and get everybody else to be able to do it. And the way to do that is to get them involved right back to the point I was making here with something that's going to change what you do today. okay? Don't ask me to go and do a project over there on somebody else's stuff. Sometimes having outside eyes is helpful, okay? Sometimes having outside eyes is helpful, but what's really important is how am I going to change what I am doing in my day-to-day life, and how can I make a difference to my area? And then they're flocking to us. We started off saying we're going to do some of these rapid process improvement workshops where we had an open door and where we had a problem, maybe a clinical problem, a waiting time problem. As soon as we started doing it, all of those 20 people involved that week told another 100 people what they'd done. Some of those 100 people came and said, can we do that? Then we did the next one. Suddenly that spreads out by osmosis sideways, okay? And suddenly you've got people that are now beating a path to our door. They don't know what a rapid process improvement workshop is, but they'd want to have a go at one. Thank you very much. So the rigour of the process is important, because if you don't follow a methodology which is clear and consistent, then you don't get the outcomes. So you have to absolutely be true to process. But if you have people trained, you're true to process, you get frontline people involved, actually it builds its own momentum quite quickly. And we've seen successes in reducing adult social care assessment times. We've used it in all sorts of community setups, and it took me 2 years, but 2 years in, we were invited into a general practice and actually have decimated some of their wait times using this sort of methodology. And they didn't want us in because they didn't want us to see, because we were paying them, just quite how bad it was. So again, I come back to that thing about they had to get over themselves and say, you know, that we're all trying to do the same thing. And we're not here trying to say you're doing a bad job. We're trying to say the system is under pressure. How can we change the system and do things differently? Okay? You're going to keep me right on time. It's 2 minutes past 1 and I'm stopping your lunch. So is there any other maybe final question, or have you questioned out? I think that's them. They're stunned into silence, Matthew. Should we give you the microphone?
I can take the microphone. Can you hear me without it? I've just got a couple of things to say. You can probably hear me better with it. Should we just say thank you one more time to Elaine?
Oh, thank you. Thanks very much.